truth, the whole truth, and nothing but the truth. So help me God.
Thank you. Good morning, and thanks for coming. And there's a little stack of papers like I stacked up there belong to Mrs. Riley. She had a medical issue that we had to take her to the hospital. So appreciate if you would take those for her, please.
I will, with pleasure.
Okay, have a seat, ma'am. Relax. Have a seat. Okay. As you know, Mrs. Yearwood, we're dealing with the 2016 accounts, audited accounts, and once again, you've gotten a qualified opinion. And the other thing that I noticed was that there were a number of adjustments that had to be made during the audit. Can you give us some explanation as to why so many adjustments were necessary to the accounts?
Mr. Chairman, before I start, I just want to publicly thank the finance team at the HSA for the hard work that they have been doing in order to get our financials to a clean opinion. I'm sure the Honourable Public Accounts Committee will recognize that the number of qualification points have significantly reduced over the years, and we are in a position now that we're quite confident that by the end of 2018 we'll be able to clear away these qualification points and be able to achieve a clean opinion. Now, remaining on the Auditor General's report are 4 qualification points, and those are the patient services fees and the accounts receivables. And those are areas where we are trying to strengthen the internal controls to make sure that there are controls in place that we can reliably have the Auditor General have those 2 qualifications removed. And we have also employed a third-party company in order to do our post-employment employee health cost review, and that report we have in hand, so that is something that we'll present at the next audit.
Okay, thank you very much. We were just told by your HR director, not by your chief financial officer, that it's taking 6 months to recruit personnel at the HSA. Can you explain to us why it's taking that long to recruit somebody?
Yes, sir. Mr. Chairman, we had an unexpected resignation of one of our key positions because, as you can appreciate, for the remaining part of this year is very, very crucial for us to have a lot of work in place so that we can get a clean opinion for our 2018 financials. The resignation of that key position came, like I said, quite unexpectedly. So what we have done, we have actually used a local company to fill that position while we recruit somebody to fill it permanently. And the reason why we gave them a 6-month contract is to ensure there's continuity in the work that that's being done. Because as you can appreciate, if you're bringing in somebody brand new into that position who doesn't really have the experience that is needed, there's going to be some experience that is going to have to be gained. There's going to be a learning curve. And at this point in time, we cannot let off of the pressure that we have on us in order to make sure that these things are put in place for a clean opinion to be achieved. So it's not that we knew in advance that it was going to take us 6 months. The reason being is that we know that between now and the end of the year, we have a significant amount of work to be done. And therefore, we need somebody who can be working on those items without any break in that momentum.
Some of the questions that the committee were concerned about is bringing somebody in from overseas right into the system that you're putting there. Do they have a learning curve that they're going to go through as well?
Good observation, sir. But the reason why it's not just anybody, it's somebody who is working with a local firm. And therefore, it's not just the benefit that we have from that individual is that the local company also has experience in this area, being that they have been a former member of government. So we also have the benefit of having additional skill sets from the company. It's not just one individual.
Are you suggesting that the local firm is continuing to supervise and train this person while he's working for you?
The local firm is in collaboration, yes, because we've hired the firm, not the individual. So it's the local company that we have hired in order to do the work. Okay. So there's additional skills that will come from the company that knows the local environment.
Okay. We provide every year a number of votes for specific purposes. For instance, medical care for indigents, ambulance service, mental health service, geriatric services, medical care beyond insurance, medical care for chronic ailments, separate and apart from the public health related and school health and other resources. How does the HSA access these accounts, and how do you get paid for them by government?
There are basically two categories of the outputs that you're referring to, Mr. Chairman. The one are for direct services that we provide, and then the others are for those that are for operating deficits of a couple of the departments. So for those that we are providing direct services, a billing is done every month to the ministry, and those funds are drawn down for those services. Now, if those services aren't used, then we don't draw down on their funds.
You ready?
Thank you, Mr. Thank you, Ms.
Just hold on. Ms. Lynn, somebody else is coming to assist you?
I was expecting someone, yes, but with the transition, she hadn't arrived as yet.
Oh,
so I would appreciate if she could come
okay,
in.
all right. When they're here, just bring them in.
Thank you so much.
All right, sorry, Mr. Chris.
Thank you, Ms. Lizette, for coming here today. Just what we're trying to understand is going back to this. You said it was a local firm from a former government person. What's the name of that firm?
FinCor is the name of the firm. It's a local company.
All right, I have an idea who that is. No, where I'm a little bit curious about is that I'm looking at the 2014-2015 financial statements and 2015-2016 financial statements. And on the face of those statements, on both, page 9 on both years, is that I look at training in 2015, we budgeted $305,000, we spent $181,000. And in 2016, we budgeted $414,000, just thereabouts, and we spent just under $153,000. What really jumps out at me is that when you have a department of over 40 staff members, and then we basically have to bring in someone from outside an organization with over 800 staff, it does not bode well, one, for succession planning, and two, in terms of the training and development of the staff members that you have. And I've said this speech, and kind of forgive me, because my colleagues, they're probably going to be hearing it for the third time. One of the things that we're looking for, at least I'm looking for today, and I take the balanced scorecard approach in terms of kind of looking at the performance of a business, where we're looking at the financial performance, the internal controls, and the internal processes, and also basically new services that may be coming online. What we're looking for is a certain amount of comfort level that, one, management is aware of these issues, and then two, that management has a plan to deal with these issues. And in a nutshell, this is $100 million a year organization. It's not a small amount of money. It is one of the largest entities and one of the largest areas that government spends money, and where the taxpayers and the people of the Cayman Islands invest a lot of money in. And what we're looking for at the end of today is to have some comfort level in terms of what is going on at the HSA, And that's the reason why we're here today. I mean, there are some departments that are performing quite well, and they're not here. And the fact that we're having this public hearing today says that there are questions both from the public and also from the members of this legislative body with regards to what is going on with the HSA. So that is the reason why we're here today. If everything was hunky-dory and we were happy with everything, we would have gotten a letter from the chairman that we would have been pleased. But the fact that we're here means that we have questions. And one of the things that we're looking for, at least I'll be looking for from your testimony today, is the strategic direction and also efficiencies. I can say to you, even in your earlier statement when you were thanking the finance team for their work, we are also very grateful for the work that the finance team has put in. But for us, we're putting in the hours, and what you're putting into the hours are two different things. And I can say to you unequivocally that, at least speaking for myself and some other members, that we were not overly impressed in terms of the responses and also the overall understanding of the financial issues thus far. So that in itself is an area of concern. And I'll be curious to know, and we'll take this up with the chairman when he comes here today. One, what is the complement to the finance subcommittee on the board? And then two, how is the CFO evaluated? Because at the end of the day, I can say to you, as a former CFO and a former board member, the ability to evaluate a CFO is different. If you don't have certain skills, you cannot evaluate a CFO. And so from that standpoint, we need that level of comfort. And so far, in terms of the numbers that we have been getting, I can tell you, not impressed from that standpoint. So I just need to state that for the record. So what we were looking for from your testimony here today is more on the strategic side and more on the efficient side. And to give credit where credit is due, I'm checking the start out now. Over the past 5 years, you have increased revenues by 19.5 million, and you have increased expenses by 16.6 million. So in essence, you have gone up revenues by 22.8%, and your costs have gone up by 18.4%. For my finance colleagues here, they will tell you that's positive jaws, so that's good for business over a 5-year period. The problem is now, when you start looking over the last 3 years, revenues have gone up by 4 million or 4%, but expenses have gone up by 6.8 million or 6.8% over the last 3 years. So looking at 2014 to 2016. And then just between 2015 and 2016, revenues are up 2.2 and expenses are up 2.1. So you're basically flat now. So what we're looking for, and then when you realize that where the cost is going up and we're making this kind of revenues and we're not collecting the cash, at the end of the day, that really means nothing. And the fact that over a 12-year period we'd accumulated, I think it was like about 58, 59 million and accumulated, and in the last 2 years, we added 53 million to accounts receivable, says that there's a serious cash collection problem. So from that standpoint, it's important for us to get some comfort level that the management team at the HSA is aware of these issues, 2, have a plan, and then 3, have the will to get it done. And that's really what we're looking for here today. Thank you.
Thank you very much. Through you, Mr. Chairman, if I may respond to that, I think that the Honourable House can be assured that there is the commitment that we are going to make sure that all of these qualifications are removed from the books. We have had a number of gaps in the controls over the years, and as you can appreciate, you being a former board member with the responsibility for finance, you would understand the complexities for the HSA are quite varied. And what we've been doing over the years is basically chipping away one by one, because they're not just varied, but they're many. And therefore, we're at the point now, we have, what we have done for this last year, we had a report done to look at all of the remaining gaps that we have with our controls. Because, you know, over the years, we have been looking at it internally, and we have been trying to make sure that there are controls in place to speak to all of those deficits, to fill the gaps. But what we have now is basically a scorecard with the additional recommendations for the controls that are there. And I think that I am quite confident as a CEO that we have the team in place with the additional resources to help us make sure that all of those gaps are filled. We have worked with the current CFO. I know that it may, just by the face of it, it may look like there's not a lot of work that has been done over the years, but I can guarantee you that she has been working very diligently with the team. And you spoke a little while ago about the aspect of training, and that I think is a very key point, because when we started off in 2002, we were a very manual-based system. And over the years, we have become electronic, and there's been a number of other financial regulations that have come into play. So we've had to work with our staff in order to try to keep their training level up so that they could basically work with the changes and keep abreast with the changes. We now have another training plan that has just been rolled out for the patient financial services team to again get them up to speed where those needs are, especially in the area of the registration. As you know, if you've been users of the facility, when you come into the organization, that's a key point of contact. If the right questions aren't asked and the right documents aren't produced at that point in time, often the services that are incurred might not be collectible. So we have really focused on our registration team, and just a couple of weeks ago we had them in a training session, and we need to continue to do that internal training to keep them abreast of what is expected of them as an organization, and also what is expected of them from the finance industry and the insurance industry.
Thank you, Mr. Chairman. Through you. Good afternoon, Ms. Yearwood. Quoting from the Auditor General report, trying to quote it as much as possible, it stated, overall, the government lacked the resources and information required to manage the healthcare system effectively, the lack of oversight and enforcement practices, and the failure to properly oversee budgetary usage to ensure value for money. She goes on to state that without the resources and information needed to effectively manage the healthcare system, the government cannot provide assurances to legislators and the public that it delivers high-quality healthcare and achieves value for money. We were told earlier on from the previous HR director that the HSA has approved funding for 890 total staff, but presently it only has 833 on staff. We also noticed from the Auditor General report that overtime for the year ending June 30th, 2016 saw an increase of 310% over and above what was budgeted for. Obviously, this additional overtime presents wear and tear not only on your human capital, but certainly also on your budgetary financing. Can you state to this committee what are the reasons for the delays in hiring the 57 additional staff which budgetary financing has already been approved for?
Thank you very much, sir. Through you, Mr. Chairman. There are a number of reasons that create challenges for recruitment. One of which is the difficulty recruiting some of our professional staff. There are some positions that have been on our books now for a couple of years. Oncologist is one that we are just not able to attract the individual that we desire with the current remuneration package that we have. And we've been in discussion with the board about that, and adjustments have since been made. So we hope that this attempt now for recruitment will be more successful. That also is a problem with some of our other clinical staff. Nursing staff, there's a high turnover. I think you may have recognized that in some other jurisdictions, they're actually given they're given citizenship papers to certain professionals. So we've been having to compete with that sort of environment. And we over the years, the professional team, we have been trying to make sure that we have other areas of satisfaction other than salary, but in an environment such as ours where the cost of living is high, that does play in, unfortunately. There are some of the other areas as well that has impacted on the overtime. For example, where we have extended sick leave. We've had a number of deaths, unfortunately, in our staff cadre, and we've had some extended sick leave with some various serious illnesses. So what we have to do in the interim, we have to, to cover those vacancies with overtime until we can recruit. And in some areas, those recruitments have been challenging. There's another area as well that we're working on outsourcing the service. So there has been a number of vacancies on the books in that department, And we have chosen to keep those until we can go through the outsourcing process, rather than having to displace any additional staff that are hired in that department. So the reasons, Mr. Chairman, are varied, but we recognize that this is a key area and we are diligently working to fill those vacancies as we speak.
Mr. Chairman, again, just through you, of the 57 staff that have been budgeted for, would you say those 57 staff are clinical in nature or non-clinical in nature?
I would say it's both. The majority are clinical in nature.
And as it relates to the overtime, the Auditor General made a very keen observation when she stated that reliance on overtime to such an extent could have a detrimental impact on staff well-being and the quality of care. Speaking specifically on the quality of care, there have been certain suggestions before this committee that, for example, the hours worked by your staff are having a detrimental impact on the patients at the HSA. Would you agree that this is happening, or would you disagree?
Mr. Chairman, through you, I disagree with that. It certainly has not come to my attention because whereas we are focused on the quality of patient care, we're also focused on the quality of staff, the HR environment that we provide for our staff. And if ever that had come to my attention, we would definitely make sure that that is dealt with. If the staff are tired, we definitely ensure that they have time in order to be able to have some downtime. Having said that, our staff work very hard. And of course, any number of overtime hours can be quite taxing from time to time, but it's not something that is sustained because overtime is shared amongst the staff. It's not one or two individuals that do the bulk of it.
Thank you, Mr. Chairman.
You currently work an 8-hour shift or a 12-hour shift?
Mr. Chairman, not with any respect, but I work a 24-hour shift.
No, I'm not talking about, we're talking about your staff.
Nurses
Oh,
and
no,
doctors.
well,
We're not talking
both.
about managers don't work shift. We know that.
Okay, I thought you said me. The professional staff, they mainly work a 12-hour shift. For example, nursing and other clinical staff, lab and radiology, the physicians work 8-hour shifts, but they're on call as well. So they have an on-call rotation depending on the number of persons that are within their department.
Do you believe, so when you work a 12-hour shift, what are you working, 4 days on, 3 days off?
Normally it's 4 on, 4 off.
4 on, 4 off.
Yes, sir.
Have you done a cost-benefit analysis of a 12-hour shift with 4 on, 4 off versus an 8-hour shift with only 2 days off?
It's not something that we've done in the recent past, Mr. Chairman. No, sir.
Because I would hazard to suggest that nurses in particular working 12-hour shifts, by the time you get to hour 10, 11, and 12, if they're working at diminished capacity simply because they're human beings and not machines.
Mr. Chairman, I'm not sure if I agree with you in that regard. I mean, the staff, we have spoken to the staff on a personal level about, how they feel about working 12-hour shifts versus 8-hour shifts in the past. And they prefer, I guess it's something you have to adjust to, right? You adjust your lifestyle, you adjust your family.
They like the 4 days off.
And, and we don't see any difference in their in their work load and the work that they produce when they do the 12-hour shifts. But that is something that, we can look at.
How many breaks do they get in a 12-hour shift?
They get an hour and a half, so they can, they can split that up.
No, but is it regulated? Do they get a 15-minute break after 3 hours, and then a lunch break after 6 hours, and then another 15-minute break at 9 hours, or do they just take a 1.5 hours at any time that they wanted during that 12-hour shift?
To be honest, it is according to what the workload allows, but we try to encourage that they take a 15-minute break earlier in the shift, and then later on they can have, another break again. But it really is dependent on the workload, as I'm sure that you understand.
Mr. Bush?
Through you, Mr. Chair. Over the past 3 years, I've been asking questions with staff at the hospital, and make me say both of my parents died there, and you all did a good job. So I'm not here to grind the axe, as some people would say. But do you feel in the environment that you may not be aware of, because maybe you're perceived as part of it, that the staff will answer you honestly, seeing the fact that the top echelon of the HSA is viewed as a clique with nepotism and all the various other isms that go with it, that you'll get a true answer? Because I'm going to give you a few things that I've made notes of, and then you can take your notes and come back. You say that the nurses, especially the 12-hour shift, is not a problem. But I'm telling you, out of the 14 nurses I spoke to, 10 did say it was a problem. Some of the things that they said that they complained about, nurse managers. What does the nurse managers do? What is their role on the floor? Sometimes they're not even sure. Is it normal or acceptable for the nurse manager to be unreachable during the shift? I don't think. I think she should be. Locked up in the office all day, does not offer support on the help of the staff, even when they are short-staffed. And I went there, and one day a staff member said, "Come, and we'll show you." Walk in, look, then leave, and you come back and check. I sat down and observed for 3 hours. Because one thing about the hospital, you see everyone, so you can have good conversations and observe at the same time. Some of the other things beside their regular nursing duties, there's a problem at times getting medications. And this is added responsibility for the nurses, because sometimes there's patients will need medication and they have to go and get the medication because it's been used up, what they have in stock or whatever upstairs. Another thing that's amazing to some of the nurses is paper charting versus computer charting. And what they say is, why do nurses have to complete any paper charting if they are documenting via computers what they're doing? You're wasting time, paper, and it's another stressor on the nurses. These are the kind of things. I asked 2 nurses why they were leaving. And I asked them if they were given an exit interview. No. I happen to have had an in-law working there who refused to, on instructions from her husband, to give me any information, which is I can live with now, understand, because at some time they may have to come back here. But, Mr. Chair, through you, being tired, being stressed, and sometimes it won't show up in 1 week, but it'll show up eventually, leads to, especially in the medical field, big mistakes. We've had our share of mistakes. Even no much we try to cover them up, we've had our share of mistakes at that HSA. So I'm saying to you that something has to be done. I looked at very carefully. And my last question now is, how is the upper management evaluated? Are there any goals set for them? And how are these goals evaluated? And there's a difference between output and evaluation. Because you can say you can do something, but whether it's done good or not is another question. Thank you, Mr. Chair.
Mr. Chair, through you, I start at the beginning by saying that the nursing department is one of the areas that has been affected by some of the shortages that we've had. So yes, indeed, some of the nurses have had to work additional overtime hours, and I publicly thank them for doing so, because in the past and currently, our nurses put our patients first at all times. And, it rather surprises me that you have heard from them to say that they don't have the support from management. You mentioned a word earlier that quite concerns me, and that is nepotism. in a country like Cayman, it's very difficult to say that we don't have, or we have a policy where we don't hire family members of staff that we have there, because then it would be, our recruitment challenges would be much different.
Mr.
right?
Chairman, through you, Madam, just interject 1 second there. Nepotism does not necessarily have to be family. You can use the word cronyism with friends. A perfect example, you had a young Caymanian on temporary for 3 years. But yet, someone came from the church of a certain high-up person in the hospital. And these are facts, and I got it all. Because one thing you all have learned since I've been sitting here, unless I got my facts, I don't say nothing. One, that individual had no more qualifications than the Caymanian that was there. But in 6 months, they were confirmed. But the young Caymanian was kept on temporary for 3 years. Those are the things that why I can say you can ask them all they want. They are not going to, because the view of the top echelons of the thing, the staff will not. Maybe if you say, put a questionnaire or put your complaints in writing on a piece of paper without any name to it, then maybe you get some truths.
Thank you very much, sir. Through you, Mr. Chairman, just to continue to respond to that, we do have our HR policies that are rolled out. I personally do not recruit any of the staff other than in the senior management team. However, I do trust that the practices are carried out. However, where there are possible breaches in those policies, and you bring to me those situations, if there's somebody in particular that you have a concern that we have not followed our process, I will endeavor to look into that to determine whether that is the case and hold the relevant managers or recruitment officers accountable for that. Having said that, you mentioned that the nurses have exited the organization without having had the opportunity for exit interviews. And I know this is something that the HR department is doing. I'm not saying that everybody agrees to an exit interview, but that is part of the performance, that they are to offer them an exit interview. And and recently we got back a report with some of the things that that people were saying when they left, and I was quite pleased actually with the information that they gave us. So the reason why they were leaving was usually to do with family reasons and not necessarily any reasons that they felt they were not treated properly within the organization. You mentioned that the staff, the nurses were having difficulties accessing medication, and therefore they had to leave the unit to get that for the patient. I must say that within the last few years, we have actually put in place an inpatient pharmacy, and that has really, really helped significantly in the way that the team are able to administer their responsibilities to patients, because that is staffed by the pharmacy team. So if there's supplies that are needed, pharmaceutical supplies that are needed that are not on the unit, then it's not the nurses that would necessarily have to go and retrieve them. The pharmacy staff are able to do that. So I'm very happy about the performance of the inpatient pharmacy. In fact, the recent report that I got from them is that they're doing such a good job. We need to expand the location that they're in, because they need to, they want to have additional supplies in the inpatient area in order to be able to service the needs of the patients. You mentioned about paper charting, sir, and I'm not sure exactly what that is related to, because we are fully electronic, and whereas there may be some charts that are not in the electronic health record, there certainly isn't a duplication of records that I'm aware of, but I'll be willing to listen offline to see what that duplication and documentation is, because already there's enough required documentation that I certainly wouldn't support any duplication in documentation if it's in the electronic format, and we're requesting it in paper format as well. So I'd be interested to talk to you offline to find out what that is. And the last item that you queried was how the senior management team is evaluated, and those objectives are directly linked to the strategic objectives for the year, and anything that is directly relevant to their departments. Those are objectives that they are required to report on, and we work with them in that regard. I hope that has answered all of your questions, sir. If not, I'm definitely willing to
Mr. Austin.
supplement.
Thank you, Mr. Chairman. Taking a look again at the finances of the HSA, the Cayman Islands HSA, according to the Auditor General, has failed to maintain the legally required cash reserves for at least 5 years, 2012 to 2016, which a lot of that has been pegged to unpaid patient debts or bad debt. According to the Auditor General, the amount of account receivables the HSA deems to be uncollected, some $94 million, is greater than the HSA revenue earned for 1 year in patient services, some $84 million in 2016. In short, the authority is not following its own relative law as it relates to cash reserves. In your view, what is the solution to reducing the amount of bad debt, both in terms of recouping this outstanding bad debt, which has largely been written off, but more importantly, reducing it for the future?
Thank you very much, sir. Through you, Mr. Chairman. In regards to the bad debt, that is something that we have been working with to reduce over the years, and I think that you'll be quite pleased that we are now at the point where we have significantly reduced the provisions for the bad debt for this year because our collections have significantly improved. Now, that has not been an easy task. As I'm sure you can appreciate, we have done this with a lot of negative feedback from the public as well. But what we're trying to do, because we know that government has provisions and programs in place in order to make sure that persons living in Cayman who do not have the means to pay can access health care. So what we have been trying to do with our payment policy, implementing our payment policy over the last few years, and I must appreciate the support that we've had from the board, because they have really worked with us to make sure that patients receive the care that they require, but we do that by helping them to access the programs that are available within government. One being the indigent program. So we have been seeing a lot of patients at the HSA over the years, treating them and not necessarily helping them to access the resources that are in place through the Needs Assessment Unit and the Children and Family Services. So if you look at the records in recent years, we've actually had an increase in the number of indigents, but it's because we are actually working to give them the coverage that they require now. So when they come to the health services, it's no longer documented as bad debt or doubtful debt. It's actually we can actually collect for those services. So I think that that's one of the areas, making sure that when people come, they have the means to pay, because we do have an insurance law, and the number of persons insured is still around, I think it's 90%, is the last that I've heard. So that 10% that aren't insured, we have to work with them to find out why they don't have insurance. And if it's because they're not working, or if it's because their insurance plan has been exhausted, that's when we have to assist them at accessing these other programs and resources. So that's one of the areas. And then when I spoke earlier about what we're doing in-house in order to strengthen the controls, that is another area. So where we have bad debt, we need to make sure that we have done everything that we can in the beginning to give the patient financial services team the best opportunity to be able to collect on that debt, because we know the older the debt, the longer it is owing, the less the chance of us collecting for it. So there's a number of prongs that we have approached this through to ensure that we reduce that bad debt. And the other thing that we're working with, because I know at the last PACs we talked quite a bit about why aren't we writing off the bad debt? And that is something, because this financial statement was already in play when we had that discussion, and we're working with our board in that regard as well. So the efforts that we're making now in order to have to augment, I should say, the internal team and their collection efforts is really to ensure that we have done absolutely everything. We've analyzed the debt. We've done everything that we can to collect it. So at that point, we can reassure the board, that we have done everything that we can, and that truly is bad debt that is to be written off. I think over the years, we've just kind of been holding on to it, thinking, you know, we got to try to do something else to collect this, because surely we can't be writing off all of the debt. But the efforts that it takes to collect the debt that's, you know, over 365 days old is significantly more than when it is a new debt.
Sorry, please. Mr.
Yeah. You say that you're trying to increase your access to indigent getting medical care, but yet your provisions in the budget remain flat.
Mr. Chairman, what we are doing is we are working with the needs assessment unit, and if that amount is exhausted, if the amount that's exhausted in the output, then we go back to the ministry and have a discussion in regards to a supplementary. But what we put in the output budget is based on the trend that we have seen in the past year.
That's the difficulty I have. But while I accept the fact that you're making a greater effort to get people through that, it's not represented in the numbers because there's no increase. And you say it's based on actual patient billing for all of these areas.
Yes, sir, Mr. Chairman. There's another fund that the ministry also pays from other than the output, and that's a segregated insurance fund. I think you are aware that that is a fund that is put aside for the indigent program, so that too is used to supplement the actual output. So that's why the output is a fixed number, and then we draw down on those figures.
How is income from these votes treated in your account? Is it included in your patient revenues?
Yes, Mr. Chairman.
Okay. Your CFO said that you just contracted, I think it was Deloitte, for 180,000, I believe was the figure, to analyze your bad debt. But yet she insisted that her bad debt is an aging criteria only is applied. What is this company going to analyze if your bad debt criteria is simply an aging one?
I think that maybe that was either misspoken or misinterpreted. We hired the Deloitte company in order to assist us review our controls that are in place so that we can make sure that we are targeting all the right areas when we say that, you know, we're fixing all the controls for a clean opinion. As far as the bad debt is concerned, that is something we have been looking at internally to analyze it, and we are going to be hiring an external company to augment the efforts that we're making internally, and that is basically to escalate the debt to the courts if necessary in order to make sure that we collect it. And let me just also say that what we're doing, because we recognize that it is not an easy task, obviously, because what we have actually yielded over the previous years has not been great. So what we want to do, what we have done is actually to say that we are going to be piloting this. So we're going to give them a segment of our debt and see how they can actually do in regards to collections, and then we will roll out a process once we see how that works.
But she also said that you just, through an RFP, changed your debt collector and given it to a major law firm. Those are the ones now that the RFP, you're only giving them a sector of the debt. Is that division being made on an annualized basis or a time, or what criteria are you using to decide what chunk you're going to give them?
Yes, sir, Mr. Chairman. What we're doing with that company, because you know it is a pilot that we're doing, we're giving them $1 million. We're giving them 2 years to collect, and we're giving them anything that's over $1,000 that is over 365 days old.
So out of the 122 million, there's only 1 million that is individually charged for over $1,000.
That's correct. That's to start with. And then we'll continue from there.
So you're saying that out of 122 million in bad debt, there's only 1 million of that that is made up of charges that are greater than $1,000?
No, sir. What I'm saying is we've given them one segment and we're asking them to perform on that in that regard, to help us to collect in that regard. And dependent on their performance in the collections there, then we will determine how we move forward with the balance. Rather than giving them the whole debt and then leaving it when we could actually be working to do other things in-house with it.
So, sorry, Mr. Chairman, I just want to understand this for the record. The firm that we're hiring, we're only going to give them 1 million of the debt that is over 365 days.
That's what I said, Mr. Chairman. We've given them that initially to work on, and when they have completed that, then we can fine-tune the process to ensure that we can then expand on that to be able to learn from some of the lessons and be able to compound that.
Sorry, just for the record, based on the 2015-2016 financial statements, the amount that is over 365 days is $80 million. And we're only going to be handing 1 million of the 80 million out. So what's going to happen to the other 79 million?
Mr. Chairman, what I said was that what we're doing is we're starting there, and then based on how we perform and based on what works, then we will be expanding that. So that's the only.
What time frame is that?
We gave them
2 years.
2 years.
You're giving them 2 years to collect 1 million, and then so in the meantime, the bad debt continues to grow.
And in the meantime, we will continue our internal efforts, Mr. Chairman, to collect.
But the evidence before us, based on the numbers, is that your internal efforts are to naught, because you're gone. You took the HSA took 12 years to get to 63 million in collected bad debt, and 2 years to go to 122 million beyond that.
Mr. Chairman, I think but the last 2 years, what has impacted the bad debt is really the doubtful debt, in that we had provisions made for claims that were not adjudicated on a readily basis. So that doesn't necessarily mean that it's bad debt. We would have collected on some of that subsequently.
So I don't want to accuse you of cooking the books, but that's what it looks like if you're putting things into bad debt that you know are not bad debt.
So,
Mr. Chairman.
Sorry, just to keep it, I guess, more simple. If you look at the audited financial statements in 2014, you had a total of just under $69 million in accounts receivable. And at the end of 2016, you had $122 million. So that was like $53 million increase in accounts receivable over a 2-year period. And that, if anything, is alarming, as going back to what the chairman said, considering that you took 12 years to get to 69 million. In the last 2 years, you added $53 million. After it took 12 years to add 69. So that massive increase over the last 2 years is really alarming. And I think that's really where the chairman is. So ignoring the bad debts and the allowances, this is just account receivable.
Absolutely, absolutely. And I completely understand where your concern would be as a PAC's committee. However, those, like I said, the recommendations that we discussed in September 2016 in regards to the definition of doubtful debt versus bad debt have not actually been implemented, because this would not have been implemented in the June 2016 financials, right? So that's where you see the difference. So again, it comes down to a matter of definition, doubtful debt versus bad debt, because a doubtful debt is because we have a policy where we put in place a provision for anything that's over 30 days old. So that's where you see that the agent would have then been the reason why these debts were actually provided for, whereas afterwards we would have collected. So that truly is not the $53 million for that 52-year, for the 2-year period. It would not have been.
Sorry, Mr. Chairman. No. These are the numbers that the PSC is working on that the Auditor General audits. And what these numbers say is simply this. At the end of 2014 financial year, $68,740,553 was owed to the HSA. That's an audited number. What it also says at the end of the financial year 2016, $122,324,869 is owed. This isn't about allowances. This is money that is owed to the HSA. And what we're saying is that in the space of the last 2 years, a total of $53 million was owed to the HSA. And when you consider that during that period of time, that you guys would have basically made around $200 million, it basically means 25% of what it is that you have in income isn't being collected. So this is just what is owed. This is not about any definition. This is just raw. And why it is alarming is that at present, at the end of the financial year 2016, $80 million was owed. And you're saying now that you're going to do $1 million on a test case for 2 years. So the $79 million, you guys are going to try to manage that in-house while this pilot program for 2 years is going on. And what the committee is saying, in the last 2 years, it grew, your accounts receivable grew by $53 million. So by the time you guys get around at this rate, if you're consistent, this $80 million would be basically $133 million. And we want to still chasing. So that is really the issue. So it's not about a definition. This is about what is owed to the HSA. And it's note 5 and on page 20 for both the last two financial, just where the information is coming from for ease of reference.
Mr. Chairman, through you, can I refer the committee to page 10, and then I'll ask my financial controller just to run you through those numbers, please.
Through you, Mr. Chairman, we recognize
Page 10 where?
You're talking about the Cayman Health Services Authority accounts to 30th of June 2016 financial statements?
Page 10 is statement of changes in equity.
page 20.
Sorry, Mr. Chairman, it's page 20 on your report.
Okay, yep. That's the same one that we were looking at.
Yeah, sorry.
We do recognize, Mr. Chairman, that we have a gross receivable of $122 million in June 2016. And as explained by our CFO, that there was a major delayed adjudication of claims from one of our major TPA during that time. And as you recognize, we have also made a significant improvements in our collections going forward, July 2016 up to present. In fact, this August 2017, our gross accounts receivable had now went down to $108 million from $122 million in June 2016. So that's around $12 million reduction for the last 14 months.
So it's less than sorry, so August 2017, you're now at how much?
August 2017, it's now $108 million.
Okay, so that's 14 million down in the
because-
last
14 months.
14 months. You're doing $1 million a month in terms of bringing it down. Well, the thing about it is, if you're bringing this down by $1 million a month and you're making, was it 12 years, 12 nines, roughly about 8.5 million a month, and you're bringing down your receivables by $1 million, then we can see why it got to 53 million in the 2 years.
Yeah, because it's still because of those.
But the thing about it is, and I'm sorry, this major adjudication issue, we have already established from speaking to your CFO that 72% of your revenues are from government and the government pays. We also understand that 28% is from the non-governmental, which would be the insurance plus the private individuals. So even if that is 50-50 and insurance companies paying, we still have not gotten any clarity yet as to what the impact of this major adjudication is, because unless it's government, the reality of it is there is no way, if government is paying, that you can go up to 53 million in 2 years. So based on that and based on the numbers that she gave us, this is the reason why I had my concerns. Based on the numbers that she gave us, what it's basically saying is that the entire amount that was non-government for the past 2 years was uncollected, based on the numbers she gave us. And that is really where the issue is. And if government is paying, so if you take, for example, now, I mean, and we had basically run the numbers with her, and we went through this. I mean, you're talking about 27, 28 million thereabouts. And twice that is 54 million, of which your account receivable went up by 53 million. And government is paying. So there is a major disconnect between who's paying and where and the percentages. But either way, for these numbers to be what they are, then the breakdown of revenues can't be as out there mentioned. And if that is the case, then I am really more concerned, because that's the reason we can understand now the qualified opinion, because it basically tells me that the management of the HSA does not know where the revenues are coming from and who it's coming from. And I think that is a comfort level that we need to understand. And we can now understand why Deloitte and is being brought in to basically help them to basically recognize revenue. But this is a major issue.
Mr. Chairman, through you, I understand where the discrepancy that the member is referring to, because government is made up of Cineco and the government outputs. And Cineco obviously is our major payer.
So Cineco is paying or they're not paying?
At that period of time, there was a transition in their TPA, so the delay in the accounts being adjudicated then impacted the provision that we made for bad debt. I think that should put everything in context.
Actually, no. I've not been speaking about the provision of bad debt. I'm just looking on pure accounts receivable. Just the 120, basically from 69 million to 122 million in 2 years. That's all I'm looking at, $53 million.
Right. So, Mr. Chairman, through you, if the accounts aren't being adjudicated, obviously they're not being paid, so it's then accounted for in our receivables.
But how long, and that adjudication is still ongoing?
That has now been confirmed and
Well, then
completed.
why hasn't it been reduced by the amount that was being adjudicated? If that was the problem that created in the first place, once you got the adjudication complete, then that should have disappeared and shouldn't be a bad debt. But we're still carrying the adjudication, and you're telling us it's been paid and blaming the adjudication.
Can somebody on the government side try to explain this to us? Because I'm trying to wrap my head around this. Sorry.
Mrs. Vincent?
Well, similarly, I just wonder if you could clarify that at the point you put something into Cineco, doesn't it hit the accounts receivable at that point, regardless of adjudication? Well, then that doesn't. Well, then the adjudication shouldn't impact the accounts receivable number.
That is correct. That's what I was, okay, so I'm just making sure I'm not going crazy. All right, thanks. That has been established. Thank you. But I wanted to
Okay, I think we need to move on, because obviously we're not going to get.
Sorry,
Chairman,
Mr. Chairman.
if it helps offline, we could do some more work and do a report
Yeah,
back to the committee.
sorry.
on the
Well,
position.
Mr. Chairman, thank you. We can move on, I guess, to the area I'm concerned about, if you don't mind. Going back again to efficiencies, the HR director testified to this committee that the budget was actually 890 staff, and only 800, and she only had a complement of 833. So in essence, that the HSA was running 6% below budget in terms of the number of staff. If the HSA is below budget with regards to the number of staff, then I'm curious to know why the actual amount is actually above budget. So you're 57 staff short, but you're basically roughly $368,000 over budget, even though you're 57 staff short. And then the next issue for me that really alarms me the most is that, one, we're looking to increase now, according to the HR director again, to 930 staff, which in essence would increase, which is roughly a 97 increase from what we have right now. And that will move your staff costs based on these numbers roughly within the $70 million per year region once those positions are filled. The scary part for me is that if I take that number, then it means that over the last 3 years, staff costs would have increased by roughly 50%, but revenues over that period of time has been growing by around 9%. So that in itself is a serious inefficient use. And this is further, I guess, evidence if you look between the 2015, 2016 financial statement on page 9, staff costs actually went up by 4.5 million, but revenues went up by less than half to 2.2 million. So right there, what this is saying to us is that it's the inefficiencies is growing, and we need to have some comfort level that the HSA management and the board is aware of these inefficiencies, what is actually growing, and the fact that they have a plan in place. And if you look at it, even with the budget for the 2015-2016 year, you guys actually missed the patient services fees by roughly $5-6 million short. And just to close off and to put a little bit of context in terms of where I'm coming from, if you look at page 50 of the Compendium of Statistics that was released 2 years ago, you will see that between 2012 and 2016 that a lot of services that's been offered by the HSA has been trending downwards. Now, this is something we'll be curious to hear later on, if this is the health city effect that is now kicking in. And if that is the case, then what are the HSA strategic plans to deal with this loss of revenues in key areas while at the same time growing costs? So again, this is really what it is that we're looking for from a more strategic standpoint, that the management aware of these inefficiencies, it's not going in the right direction, and then what are the overall plans to deal with it? And I think ultimately, that is the main takeaway that I need from today. We do recognize that there are challenges, yes. We do recognize it is not easy. And I can probably say that within this entire process, this committee probably has the easiest job. You're the one who have to deal with the public and everything else. We just have to make sure that the public is getting value for money and that the health services is there. But we need that level of confidence that the management is aware of these issues and are moving in the right direction. And thus far, from the first two individuals that testified today, that confidence level has not moved. And this is really where the issue is that it's more strategic, which is your area of responsibility. And that is really what we need to understand is what is the HSA's plans? Because ultimately, this will remain a strain on the government purse and also for the people via taxation.
Thank you. Through you, Mr. Chairman. As has been identified, the staff costs have been exceeded in the budget, and we talked about some reasons for that earlier, the fact that we have overtime, and then also the health cost is actually built in. The cost for healthcare is built into the overall staff costs as well, and we've had a number of staff that have had some major illnesses. Now, where I think the HR director had alluded to is in subsequent years in regards to some positions that are actually revenue generating positions, and that's really the strategic direction of the organization, because as many of you will appreciate, the waiting times in some of our clinical areas is quite high. So we need to ensure that we can actually service the patients in a more readily manner. We are going to be including some additional clinical positions, hopefully in the next budget year. So that will definitely improve on our revenue generating basis as we'll be able to reduce our wait and time and overall improve the quality of care that we're able to offer.
Yeah, Mr. Austin.
Thank you, Mr. Chairman. Just speaking to the efficiencies in your approach to dealing with bad debt, but also so I can understand better your approach. You just stated that in past years, you, being the HSA, have not achieved much success in recouping bad debt. I think we all can accept that as quite the understatement. But you also stated that you are about to engage in a pilot program with a new debt collection agency to test their rate of collection success, starting with a small collectible of $1 million. However, in a period of 5 years between 2012 and 2016, the HSA partnered with not one, but two debt collection agencies, one responsible for overseas patient fees and the other responsible for local debt. Whilst we were not informed of the success rate of the collection for overseas patient fees, the local company was given an allotment of some $4.2 million worth of debt for collection, with less than 3% actually collected, some 126,000. Is it safe, therefore, to say that the pilot for whether these debt collection agencies can be successful has already been tested and found wanting? Or perhaps is there something different in this new agency, HSM, I believe, as compared to previous attempts?
Thank you, sir. Through you, Mr. Chairman. The strategies that we are going to be implementing with the new collection process have not actually been utilized before. As I said earlier, we will be pursuing those debts to the full extent of the law. If necessary, we will take them to court. And we believe that that is necessary for those cases that we have a good idea that they're able to pay. And then we'll be able to recoup those fees through the courts. You made reference to an overseas collection agency, but just to be clear, I think that is with Treasury. Because HSA, the only overseas debts we have are really for visitors. Those visitors would have access services on island. We are not in the position to recoup debt that is incurred otherwise.
So Sunbelt Medical, this company which is listed as an overseas collector, what is that?
Okay, my financial controller just reminded me, those are the ones who will then pursue the visitor's debt. When they leave the island, they will then pursue the debt that is incurred by the visitors. Thank you.
But don't you require visitors to produce a credit card or some other form of payment prior to?
Mr. Chairman, we do request for credit cards. Sometimes when we go to run the claim, the credit card is no longer, is maxed out or no longer in place. We have a number
You
of.
don't run it. You don't test it before you accept it.
We have to apply the charges after they're incurred, Mr. Chairman.
But
And what we try to do is to work with them as much as possible up front. But sometimes when the claims are levied, they've actually, or maybe they don't have any means when they actually come into the emergency room. They don't have insurance cards. They don't have credit cards. So obviously when they're coming in an emergency, we have to treat them and then we deal with the payment afterwards.
Through you, Mr. Chairman, one of the reports I read in preparing for this PSC was a report that was issued in January 2017 by the Office of the Auditor General entitled Ensuring Quality Healthcare and a Healthy Population. On page 3 of that report, it says, "We concluded that there are shortcomings in the government's management of some of its role and responsibilities to the extent that they may compromise the achievement of the stated aims of ensuring quality health care for the people of the Cayman Islands and a healthy population. The government does not have the resources or the information required to manage the health system effectively, and neither the Legislative Assembly nor the public can be confident that high quality health care is being delivered or that value for money is being achieved." Between this report, ensuring quality, and also the Cayman Islands health system, and as well as the National Health Policy and Strategic Plan for the Cayman Islands 2012 to 2017, when we actually go through those 3 reports, there are major concerns with regards to overall health care. And the thing that I'm looking for more than anything, Ms. Yearwood, is the fact that clearly something is amiss with the current system. And some of it would have to be changes, be legislative, some may have to be political. But what we would expect from the people into the day-to-day systems is saying, guys, listen, this isn't working. A 53 million increase in 2 years in account receivable is not working. We are not on the right path. And at some point, we need to have the national conversation as to, do we move to a universal healthcare system? Do we move to something else? But the reality of it is, there's a lot of expectations that's being placed on you at the HSA. Now, my personal opinion, and it is that personal, is I start with 2 questions. Is healthcare a benefit or is it a right? If it is a right, then it changes the way in which we administer healthcare in this country. If it's a benefit, then we continue on this path. But either way, the reality of it is this system isn't working. The reports have said it's not working. There are really no measurement practices for it. And what I would expect ultimately, and this is why the National Health Policy and Strategic Plan is important in terms of updating. Now, some of this, and I recognize that you are part of that also, some of it we'll have to deal with later on at a ministry level where policy is set. But in your role as a day-to-day person that carries out the administration, we would expect at the end of the day, not just a defense of the systems as it is right now, but what is it that you think would be the ideal scenario? Because what I'm having a problem with is that the people of the Cayman Islands are being taxed twice. We're paying premiums to the in the private sector. We're paying premiums to health companies, and contrary to being told here that they're actually collecting from the hospital, because if we accept that 10% of the people don't have insurance, let's accept that based on the testimonies we receive, and that 90% of the revenues are basically from people who have some level of insurance that comes into the HSA, there is no way under God's green earth these numbers can be that way when we're looking at the trends. And we're going to say that 10% of the people who are not insured is responsible for $53 million year growth in 2 years. Impossible. So clearly there's something amiss. And what we would expect more from your role, and this is, I guess, the one question I would like from you, in the years of being there, recognizing that every year the hole is going to get bigger and bigger and bigger. The trends doesn't show the HSA revenue is growing. There's definitely impact from Health City, and we see it in their marketing and everything else, where they're taking more local businesses. We can't be destroying costs, and we expect revenues to grow just as quickly. What we would more expect is a strategic answer to say, guys, this is what the ideal situation would look like. Now, if you don't have that answer today, that is fine. But ultimately, it is that strategic. The day-to-day stuff we expect from your team, but that strategic direction is more what it is that we're looking for. But trying to fix this, I'm going to tell you right now, between 2002 and 2017, 15 years, this hole is going to get bigger and bigger and bigger. And the solution cannot be that we continue business as usual. And that, for me, hopefully, the next time when you do arrive here, and that's more the answer and that we'll be looking at, more strategic as opposed to operational. You have a big organization, it's over $100 million a year. It's a lot of moving parts. I do not expect you to know where every single screw and every single joint is. But what I would expect is ultimately, in your role as CEO, you know the direction of where the HSA is going. And based on these numbers and the trends in what we're seeing when we put everything together, the reality of it is the numbers aren't trending the right way. It's not a sense of optimism, so we need to change strategic direction. And I think this is where the ministry and the HSA will have to work together now to say, guys, what else can we look at? But bringing in consultant after consultant, trying to fix this isn't going to work.
Mr. Chairman, if I can just compliment the remark and questions my learned colleague just made, looking for some degree of a strategic direction. 5 years ago, the government introduced what we understand to be the strategic plan for healthcare in an attempt to return some degree of consumer confidence to those who would utilize the facilities, but also at the same token, manage expectations from a governmental standpoint. It was called the National Health Policy and Strategic Plan for the Cayman Islands, 2012 to 2017. But like most strategic plans, according to the Auditor General, this has not been fully executed. The Auditor General stated, and I quote, implementing the NHPP will result in some improvement to the health system, but some goals are too ambitious. The good intentions are there, but there is not the means to fulfill them. Going back to the means, can you state for this committee what aspects of the NHPP have been implemented versus what aspects still lack the necessary means to achieve them? And of those quote-unquote necessary means, is that connected to a lack of human capital?
Thank you very much. Through you, Mr. Chairman. I'll start off with the first member's comments in regards to the strategic direction for the HSA. We have a strategic plan, and we have had discussions over the years in regards to the direction of that plan with the ministry and other stakeholders, because as you can appreciate, it's not something that, we can decide on our own, because we all know that where we're really going to make an impact on the cost of healthcare is with prevention. After, the individual has high blood pressure and diabetes, and obviously the cost of dialysis is quite high. So we need to look at exactly what you spoke about as far as health is concerned, whether it's a right or whether it's a benefit. And we have been having dialogue with previous governments as well in regards to primary health care, the preventative aspect of it, because we believe that, if we as a country had the funds to be able to really put into that area where we could make primary health care something that is more of a right according to the WHO principles, then I think that in the subsequent years we will see an impact to the cost of health. But obviously that is a costly exercise, and as a country we need to be in a position to be able to do that. However, the discussions continue with the ministry in regards to how we can fund the primary health care. We have funds in the budget now for that, but persons are still having to fund that through their insurance if they have insurance available. Moving on to the second member's question in regards to the national health policy. The national health policy is a ministry health policy that involves health services throughout the islands, not just at the HSA. There is obviously implications for the HSA as well, but I'm sure that the Chief Officer will be able to speak better to that later on.
Just a couple of final questions from me. When your staff work 12 hours, they get paid for 12 hours straight time, or 9 hours straight time and 3 hours time and a half?
Mr. Chairman, we look at the weekly allocation, not the daily allocation. So we look at the 37.5 hours per the week. So they would only get overtime if they were to work over that.
But the labor law does say that anybody who works over 9 hours in a single day period, is entitled to overtime for anything beyond 9 hours.
That's right.
So are you getting the staff to sign a disclaimer on that?
Yes, sir. Yes. Thank you very much.
Mr. Chairman, I just have one final question. From a strategic standpoint, Madam CEO, where do you see the HSA in the next 3 to 5 years?
Mr. Chairman, through you, we see the HSA in a significantly stronger position as far as our financials are concerned. We will be able to collect better on the receivables that are owing to us. And we see ourselves focusing on what we are currently doing well. We are in the position that we have started an accreditation process, and we hope that will be completed in the next year. And we believe that we will be providing high quality services on the services that we are currently providing, and doing that well, rather than expanding the scope, because as we know, we have a number of other players in the healthcare market locally.
Any more questions? If not, thank you very much, Monsieur for attending. We'll take our lunch break now, and we'll come back at 2 o'clock.